parietal lobe is a complex structure which mediates a variety of functions, including language, the body image, memories of the body, the experience of physical pain, and control of the hand. The parietal lobe mediates the body in space, receives considerable visual information from the lower visual fields, and constantly watches the body and the movement of the hands from the lower visual fields, as well as performing a matching function between visual, auditory, and somesthetic stimuli in order to create complex multimodal concepts. What we're going to do now is move on to the parietal lobe. And one thing I want to point out is it also relates to the temporal lobe. Visual information primary, then it gets to the association cortex, and then what happens, visual information is being transmitted into the temporal lobe, where extremely complex processing is occurring, and it's also being transmitted up into the parietal lobe, where a whole different type of processing is occurring. So we have the stage, primary, association, and then it's going up into the parietal lobe, and it's also going down. But when you get up here to the parietal lobe is receiving visual information only from the lower visual field, from the lower half. So the parietal lobe gets visual information. It only sees everything from the lower visual field. The parietal lobe is perceiving the lower visual field. And there's a reason for that. What's in the, if you're staring straight ahead, you're walking or moving, what's in the lower visual field? Yourself. Right. Most of you are in the lower visual field. Your body. What in particular of importance might be in the lower visual field? That's right, your hands and your feet. Okay, so when you're moving your hands, what's actually, your parietal lobe is watching your hands. Your parietal lobe is watching your hands, and your parietal lobe is watching your feet as you're moving, and your parietal lobe is watching most of your body from the lower visual field down. Convenient relationship because the entire body is represented in the primary receiving area in the parietal lobe. Here is your beginning of your parietal lobe. This is your primary receiving area. I mentioned before about Brodmann's areas. So in the strip of tissue, in areas 3, 1, 2. Areas 3, 1, 2 are part of the primary receiving area for your body. And what they are receiving information from your skin. But just in general, tendons, muscles, muscle spindles, tendons, joints, moving your elbow back and forth. All this different information from the body is all being transmitted into the primary receiving area. So in consequence, what happens is your entire body is being represented at the skin level, at the muscle level, at the joint level, and it's represented in accordance with its sensory importance. So there's a tremendous amount of information. Hands are very important, elbows not as important, so tremendous amount of representation for the hand. The face is very important. Primary receiving area in the parietal lobe, the entire body is being represented at all these different levels. What then happens is that information is transmitted to the called area 5. 3 transmits to 1. All of them transmit to area 5 and also transmit to area 7. Area 7, this part of the parietal lobe, is also receiving lower visual field. Okay, so what's happening now, so this is a neat relationship. So all this information about your body, tactile, etc. sensations, are now being sent to a part of the brain which is also watching the body at the same time. If you wake up in the middle of the night and you pop open your eyes, some of you may have had the sensation, at least briefly, where you don't know where your arms and legs are until you move them. The moment you move them, you might know where your body, where your arm or your leg is. There are cells in here that will receive information from the elbow and from the shoulder, from the ankle and the knee, so that it can tell what position your body is in. Just to recapitulate, all sensory information, everything from your body, from your face, etc., is going to go up through the brainstem, and then it's going to make its way to the thalamus. And you can see these nuclei presenting, transmitting information up into the superior parietal lobule and to the primary sensory receiving area. Information being received here, there's also connections back to the thalamus so that if you need more information about what's going on, so you shift attention. Again, you're sitting there in class, there's actually all this tactile stimulation you're receiving right at this moment. Your shoes, your clothes, you're sitting down, your hair, all of this, and if you shift your attention, you could suddenly be feeling all these different sensations. But all that information is there. But the point is that if it was all making its way to the neocortex, you'd be overwhelmed, you wouldn't be able to pay attention, you'd be constantly uncomfortable. So there's transfer back and forth between the two, preventing, and then again, the frontal lobes is sampling here and here, so you can direct your attention, for example, on what I'm saying versus on the feeling of your socks or your underwear. All this information is received in areas 3, 1, and we're talking about cutaneous, from the skin, from the joints, from the tendons, so that all this body information is being received and is transferred from 3 to 1, and then it goes to area 5, and then it goes to area 7, so that you end up with the entire body being represented. The entire body is represented in accordance with its sensory importance. So there's a huge amount of area devoted to the face, huge amount of area devoted to the hand, very little devoted to the knee or to the elbow and so on. All this information goes off to the area 7. You actually have multiple representations of your body image, your thought about your body, your ability to visualize your body. As we know, lower visual fields is watching the body. All this visual information is also going up to area 7 so that you're actually watching your hands. Your parietal lobe is watching your hands constantly and your feet. But what it's also doing, it is analyzing depth, it's analyzing where other objects are located in space. And what this enables, by matching all this body information with perception of visual space and where objects are, enables that quarterback to be able to throw that ball or that spear, throw that spear, enables a person to be able to dance, enables the person to be able to walk without bumping into things because all this information is being perceived. So the whole body in space is being represented, which enables you to do complex activities. Left parietal lobe maintains an image of the right half of the body, but the right parietal lobe maintains a bilateral image. It maintains an image of both the left and the right half of the body, so it has like a bilateral awareness of the body in space. In consequence, if you had a left parietal injury destroying the left body, the body image represented here, you don't generally see, a person doesn't neglect the right hand. They will still recognize it as their own. The reason being is because the right hemisphere has a bilateral image. So the right hemisphere is aware of both halves of the body. By contrast, if the right hemisphere and the right parietal lobe is damaged, the left parietal lobe only has an image of half the body. If you had a massive stroke that destroyed this area, you would lose all sensation of the left half of your body. because the whole body is represented there. If we had massive damage in this area, your entire map, entire sensation of your body, your entire image of your body would disappear. And because you would lose all awareness of the left half of your body, you would no longer know you have a left half of your body. Patients have had this happen. They complain, there's somebody else in my bed at night. How do you know that? Well, because I keep bumping into their hand and feeling them. This is called, words called neglect, or hemi-neglect, hemi-neglect. Give you an example from a patient. Patient I saw. Person had massive right parietal lobe damage. I go into their room. They've got their hair combed on the right side. She had her lipstick on and makeup on the right half of her body. She had her hand, arm through part of her clothes on the right-hand side. The left, no makeup, hair wasn't, and her arms just hanging there limp. Okay, so I go into and examine her. Please raise your right hand. Okay, now I want you to raise your left hand. She raised her right hand. I go, no, no, no. That's your right hand. I want you to raise your left hand. She can still talk because the left half of her brain is fine. The left half has the right half of the body. So she's moving it around. So I go, can you raise your left hand? She goes, well, I did, doctor. I raised my left hand. I go, no, no, no. That's your right hand. I want you to raise your left hand. Can you raise your left hand? And again, I go, no, no, no. And I reach down, I pick up her hand. I go, I want you to raise this hand. Can you raise this hand? And she looks down at it. She goes, that's not my hand. I go, sure it is. That's your hand. She goes, no, it's not mine. I go, yeah, this is your hand. Look at it. This is your hand. She goes, no, it's not my hand. It's not mine. I go, well, whose is it then? She goes, well, maybe it's yours. I go, no, no, I already got 2 hands. So I hold up the hand some more, and I go, take a look at this hand. Don't you recognize it? She goes, no, that's not my hand. I don't know why you're doing this or telling me this. I go, look there at that big, huge stone on your... And she goes, my wedding ring. Somebody stole my wedding ring. Classic syndrome. It's called agnosia. She no longer recognized the left half of her body, and even when you showed it to her, she did not know it was her left of her body, because the whole area of the brain that perceives and analyzes information about the left half of the body is gone. A person would have no knowledge of their left half of their body. I gave you an example of this before. They'll only dress the right half, they'll only put makeup on the right half. If you show them the left half of the body, they'll deny it's theirs. You show them the hand, they'll say it belongs to somebody else. At night when they're in the hospital, I've had patients complain that somebody else is in their bed at night. How do they know? Because they roll over on and touch them. They can feel this other person when it's actually just the other half of their body. Now you wonder how this could possibly be, but let me show you some tests I do, which is sensitive to the right parietal, right hemisphere. I ask a person, draw me a clock, put all the numbers in it, and make it say 10 after 11. Well, here's what the person did. And you might say, well, how can they not know? Yet they draw the clock, and the left half of space, the entire left half, not just the left half of the body, but the entire left half of space disappears. Why do they do the whole circle? Because it's almost an automatic thing. If you tell somebody to draw a circle, I mean, you go round and round. But this is an example of how they could lose awareness of the left half of space and the left half of the body. The right hemisphere maintains bilateral image. It maintains an image of the right and the left half of the body, whereas the left hemisphere maintains just an image of the right half of the body. In consequence, if the left parietal lobe is damaged, the right hemisphere still has awareness of both halves of the body. Whereas if the right parietal lobe is damaged, the left hemisphere only has a memory of half the body. It's called neglect and denial. And with the right parietal lobe injury, the body image is destroyed. The left hemisphere only has an image of half the body. So the left hemisphere can only, when you ask the left half of the brain, the left half of the brain only knows about the right half of the body. It knows nothing about the left. And that's why when you ask the person, the left hemisphere is saying, no, that's not mine. And the left hemisphere is telling the truth. The left hemisphere is doing the talking, so the left hemisphere is telling the truth and says, that's not mine. Yeah, it doesn't belong to the left hemisphere. But it recognizes the right hand is belonging to it. If a person, you have abnormal activity in the parietal lobe, such as a tumor is growing. And a tumor could be pressing on the parietal lobe, causing abnormal activity. The parietal lobe doesn't just respond to the body, but also its ability to feel pain. If somebody pinched you on your arm, that information is going to be transmitted to the parietal lobe as well. So you not only know where your body is, but you know if you've been hurt or cut. So painful information is transmitted. If a person had a tumor, for example, in this area, causing abnormal activity, it would cause these cells representing the body to start firing, and the person might feel something wrong with their body. I feel like my arm is stiff, or I feel like my breasts are engorged, or I feel stiffness in the body, or I feel shooting pains. And all of these have been documented in cases where people go into the doctor over and over, have all this pain, bad sensations, and it turns out they have a tumor. They have seizure activity, which is causing the person to think they feel pain, because they're feeling at the neocortex. Patient, for example, has a tumor growing in this area, and there's a lot of abnormal activity. And what they might do is come in and tell you that they're feeling pain. I have a lot of pain in my leg, a lot of pain in my left leg. I get these shooting pains going up my knee, and they examined, can't find any evidence of anything wrong with the leg. Oh, it must be hysteria, okay? Well, it turns out in studies of hysteria that the vast majority of people who, quote, have hysteria have the symptoms on the left half of the body, okay? Left half of the body. Another patient comes in, little boy, was having electric shock pains that were going up his leg, into his scrotum, into his penis. What's happening, you could stimulate this part of the brain and the person will say, I feel a sensation here, I feel a sensation here. But the ability to feel pain, if you cut your hand or your leg, what have you, is made possible by the parietal lobe because it has pain receptors. Consequently, a person could have abnormal activity, they could have a tumor, they could have damage, and a person might start feeling abnormal sensations and come to the doctor saying, I feel pain, I have an orgasm, and it hurts. When I'm walking, I feel shooting pains, and they examine, they can't find anything wrong with the body. You've all heard of phantom limb? Phantom limb, guy goes to Iraq to serve America and comes back missing his arm and his leg. Gets blown off in a roadside bomb. But he'll tell you that he still feels his arm, as if it's, even though it's cut off, he still feels his arm. He can still feel it. Or he can still feel his leg. And the sensation of having it thick, why is that? Because it's still represented in the brain. So just how a person could lose all sensation of half their body, conversely, they could have all kinds of weird pains on their body when there's nothing wrong with the body, or if they lose part of the body, that representation is still there. So they actually continue to feel having an arm or a leg, and it's called phantom limb. Sometimes what they feel is just the hand. They feel like the hand is sticking out of the shoulder. Why is that? Well, look how much is represented to the hand. So person lose their whole arm, they might have the phantom limb of the arm, but they'll definitely have the phantom limb of the hand, and they might actually feel like the hand is sticking out of their shoulder. And that's because so much is represented. So you get the phantom limb, very common. And it's also very disturbing to a person to keep feeling like their arm or leg is there when it's not. But something even worse about phantom limb is that a person often feels incredible pain. And the pain can come and go. So a person will go to the doctor going, I mean, the arm's been chopped off by the mortar round, and they're going to the doctor and telling them that they feel like the arm is still there and they feel like their hand is on fire, or they feel like there's shrapnel in the hand, or they feel like their hand is being twisted around. So they walk in with all these tremendous feelings of, it's called phantom limb pain. Now, this isn't really established. What happens is that the person's in a terrible accident or terrible incident where the arm being ripped off is going to be extremely painful. It's going to hurt. But what happens, the arm is gone and the neocortex is still responding with that pain memory. Your body memories are being represented in your parietal lobe. So one thing is suspected but not proved is that because the arm is now gone, no signals are being sent to the brain saying the pain stopped. So the brain is still responding as if it's still feeling agony. And again, that's called phantom limb pain, and the reason would be because that body image is still represented, and we know in area 7, that's where pain is experienced. The younger you are, the less likely to have the phantom limb, and know that the phantom limb, in some cases, it can slowly go away over a long period of time, and that could be because the cells at the neocortex, brain not getting that stimulation, not getting input from the hand and arm, those cells just start dying, use it or lose it. Or, instead of dying, they start taking on other functions. For example, if you're missing the hand, you might start getting more representation to the face. So it's like the facial area will actually start increasing its representation, taking over those vacated neurons. You destroy this tissue, but you still have axons that are shooting up there to the parietal lobe, but it has no place to go because there's nothing there. But what they might do is try to innervate normal tissue, those functions, because the axons are still there. These axons will actually look for a place to make contact. But again, it's possible for areas around it, which is why you start seeing some recovery, is areas around it might start taking on those functions because the axons are still there. If you can't feel your arm, you can't feel any sensation, it's hard to guide any type of movement because the way the brain is organized, area 4 is the primary motor area. Area 6 is that association premotor area. We talked before about how Broca's area will program the facial area so you can talk and move your lips. But these areas are actually massively interconnected. They're massively interconnected because all movement requires sensory feedback. I mean, otherwise you're going to be clumsy, knock things over. So there has to be sensory feedback. So the sensory input is being put into the motor area. So motor area, you get initially this paralysis, and eventually the paralysis, it just becomes limp. Damage, and here instead of paralysis, the their arm might hang limply. And they can still move the arm, it's just they're not getting any sensation from it, so they're not using it. It's hard to move what you can't feel. Also in cases of chronic pain, one thing they might do in chronic pain is they'll go into the spinal cord and try to actually sever those axons that relay painful information. If that doesn't work, they'll get a stereotaxic instrument, put an electrode in here, and actually try to destroy the tissue in the thalamus so that the pain is no longer being experienced consciously. That's what they might do in those cases. Let's consider, again, the entire body image is being represented. Seizures can give rise to abnormal sensations, but if the entire body image is represented, let's consider body image disturbances. We know, for example, in some females, can be as skinny as Madison Avenue model and stand there in front of the mirror and says, I feel fat. I still feel fat. I look at myself, I see fat. And she's been living on one leaf of lettuce for the last 5 months, and she's all skin and bones, yet she's still convinced she's fat. It's been postulated that there might be some type of abnormality. Now this hasn't been proved, it's just theoretical, but there might be some abnormality in the parietal lobe of these young ladies so that they have these body image distortions and think they feel that they look fat when they're not. In other words, it might actually be being perceived at the level of the brain. The question that would arise to that kind of an argument is, why is it rarer in males and more common in females? Anorexia is what I'm talking about, bulimia. I think there's a whole other explanation, but your body image, when you visualize your body, that's made possible by that parietal lobe. Okay, another aspect of the parietal lobe. We think of the parietal lobe as a lobe of the hand, commonly thought of as a lobe of the hand. Again, lower visual fields, we use our hands quite a bit, so it's watching your hands. Those of you who are taking notes, your parietal lobe is watching your hands, okay? So if you're working with tools, if you're going to make a cup of coffee, if you're going to cook some food, if you're going to take a cigarette out and smoke it, it's the parietal lobes which are watching your hands that enable you to do something like make a cup of coffee. In fact, there are neurons in the parietal lobe which will fire if you're reaching for that cup of coffee, and others that will fire when you grab the cup of coffee. So the parietal lobe is always guiding your hand movement. So if you want to play guitar, it's your parietal lobes which are watching those fingers. Again, want to smoke that cigarette, it's your parietal lobe which is guiding all those movements. In consequence, if the parietal lobe, particularly near the inferior parietal lobe, lower part of area 7, if that's destroyed, the person will become clumsy with their hand movements. To reach for that coffee, you might knock it over. But worse is they might completely lose the ability to perform complex actions with their hands. And this is called apraxia. Apraxia. Demonstrate taking out a pack of cigarettes, pulling out the cigarette, putting it in your mouth, and then lighting it. There is a series of steps involved. There are sequences involved. Take out the pack of cigarettes, step 1. Pull out the cigarette, step 2. Put it in your mouth, step 3. Take your lighter, step 4. Light the lighter, step 5. Light the cigarette, step 6. Take the puff, step 7. A person with parietal lobe injury, particularly left parietal lobe injury, they're going to lose the ability to do that. If you ask them to go make a cup of coffee, which also involves a certain amount of sequences. First you take out the cup, put some water in it, stick it in the microwave, punch in the numbers, take it out, put the coffee in, stir it. Person with parietal lobe injury, left parietal lobe in particular, you ask that person, pretend for me that you're going to take out a pack of cigarettes and light it. What they might do is they'll get all those steps mixed up. They put the cigarette in their mouth, then they pretend to take the thing out, then they light. They get all the steps mixed up. And this is called, again, apraxia. Apraxia. So you lose the ability to perform skilled movements with the hands. Predominantly, you'll get that with a left parietal lobe injury. Right parietal lobe makes it possible not only for you to throw that football or throw that spear, but the ability to draw. If you want to be artistic, do some drawing. Sit down, draw a person, draw an object. Mostly it's your right parietal lobe that makes that possible. Any of you ever seen rubric cubes? Put these things together? You have to have really fantastic, I've seen guys do this like 20 seconds with the left hand. Not with the right, but with the left. It's pretty amazing to see somebody go that rapidly. But if a person had right parietal lobe injury, they're not going to draw anymore. They're not going to be painting anymore. They're not going to be doing sculpture anymore. And they're not going to be doing any rubric cubes. And when you have that kind of damage, it's called construction apraxia. I'm giving the most severe examples, but damage can also be mild. And in my private practice, I would do subtle type testing to try and pick up on what the problem is. One thing I'd always ask people, I want them to draw for me this cross, and then I want them to draw the star. And I test them with the right and the left hand. This is a person with parietal lobe injury. We can see That right parietal lobe injury, we see neglect. They didn't complete the figure. We see greater amount of distortion on the left than on the right, telling us, again, it's a right parietal lobe injury. We also see the lines confused here. So this is a person with a right parietal lobe injury, and just simply trying to draw something is, they have a lot of problem. But if you're a good neuropsychologist or biological psychologist, you look at that and go, aha, the left is worse than the right. Thus we know right parietal. Okay, other questions regarding this? Yes?
I have a question. People with that condition, do they look the same, or is it?
It depends on how severe. Some people will recognize that it doesn't look right. Others, if it's a big hole there, no, they can't even perceive the fact that it's messed up. So they don't even realize it, which is one of the reasons you want to do testing with people, because often people are not aware of their deficit. They don't even know what's wrong. They might come someone clumsy. You know, when I threw that basketball, I had a patient come in and actually tell me this. He goes, I have this little basketball net in the garbage can. I was really good at this role, and suddenly I'm having problems. I'm being clumsy. I like playing football. I'm having to shoot baskets. He had a stroke, knocking out part of the right parietal lobe. So he was aware of having the problem, but it depends on how big the lesion is. If it's a great big hole in there, then they're going to have a lot of problem. Won't even recognize that they're not drawing it correctly. Think of a child. A child is learning language, they're learning to count. How might they learn to count? Usually, counting on the finger, 1, 2, 3, 4, or by pointing, 1, 2, 3, 4. Parietal lobe being a lobe of the hand. You have destruction to the left parietal lobe. The person might lose the ability to count. It's related to the hand. So they might not only have apraxia, but you ask them to count. You ask them to do a math problem. What's 32 plus 17? We call that acalculia. And so you can lose math ability. So you have apraxia, but they might also lose math ability. What's another thing you use the hand for when you're learning, when you're a little child? Well, mommy might point at the kitty, point at the doggy, you might point at it as a child. So actually naming and learning language is also related to the hand as a child, because children will point at the figure, point at the object, point at the kitty. So another disturbance you get with left parietal, inferior parietal, is dysnomia, word finding difficulty. Something you've all experienced in regular life is, I know that word, it's somewhere back there. So another disturbance you can get with left parietal, inferior parietal, is dysnomia, meaning dys meaning partial problem, anomia, you can't find the word at all. So this is a constellation of disturbances you might see all together. Another problem, we look at that left parietal lobe, we look at this particular area, it's getting the visual input, it's getting the auditory input, it's getting all this, okay, for the hand. All of you are writing. If you had damage in this area, you would lose the ability to write. And you might lose the ability to spell. And that's called agraphia. We know left hemisphere is involved in language, math, reading, and this one particular area related to the parietal lobe. So you can get all these complex disturbances with left parietal lobe damage. You can also lose not just writing, but reading ability, because the visual is being matched with the auditory, so that when you read a word, you know what it sounds like. So you look at an A, you know it's A. But if you had damage in here, you might not be able to match those sounds with the images, and that's called dyslexia, or if it's totally lost, alexia. So dyslexia, partial, alexia, total. And studies, we know that in boys, and maybe this is the converse about, I said why you see anorexia in females more often, but you don't see it in males. Maybe this is the counter, is that we know boys have more problem with language and dyslexia. It's the vast majority of individuals that have problem with reading are boys. And some studies have found abnormalities in the left angular inferior parietal lobule in boys who have trouble reading. That might well account for why so many males have this problem and is rather rare in females. But I'm saying maybe, and we're just throwing that out as an hypothesis. I asked earlier, anorexia in females, if that's related to the right parietal lobe, why don't we see it in males? Well, maybe what we see in males instead of anorexia is dyslexia. I'm just speculating. I don't know. Question?
What about stuttering?
Stuttering is more related to the disturbances in the left and right frontal area. The news report showing how a person with stuttering has excessive activity in the left and excessive activity in the right. After continual therapy, you actually see the activity returning closer to normal. So stuttering is really more associated with the left frontal area. Here we have again left half of the brain. Left half of the brain. There's our Broca's area doing the expressive speech. There's the primary auditory area, analyzes all the sequence of sounds, breaks them apart, sends it to Wernicke's area, which then analyzes the language. And let's say I told you, say after me, I love red pencils. You hear it here, I love red pencils, and the information is actually a fiber bundle, group of axons, bring it to here, and it comes out here. And the mouth area is located here in the motor area. I love green pencils, or whatever color I said, and then you can repeat it. This whole area right here is called the inferior parietal lobule. And inferior parietal lobule is unique to primates. We're primates, so are monkeys, so are apes, but it's unique to primates have this inferior parietal lobule, so it's something recently evolved. But in humans, there's yet another structure even more unique called the Angular Gyrus. This is conveniently located, so it sits at the junction of vision and body sensation and auditory input. This recently evolved tissue, unique to primates, unique to humans, sits at the junction of the visual, auditory, and parietal area. Well, here's how things work. Simple visual input comes here, primary area, then it goes to the association area, which puts different visual input together. So it can be recognized, for example, as a ball, or a cup, or a pen. But let's say that you wanted to name it. Well, go to here. And what happens is that you see the visual image of the pen, and I say, what is it? And you're able to take the auditory information and match it to the visual. So you're able to say, when I hold this up, what is this? It's glasses, sunglasses. What if instead I put it in your hand and you're feeling it? Okay, you're feeling the sensation. It goes up to here, hand area, feels it, transmits it to here. What am I holding? Well, you might be able to visualize it. Why could you visualize it? You could call forth a visual image of this because of this area. So I can feel it in my hand, and then I can visualize what it might look like. And with my eyes closed, I can also call up the auditory equivalent to go, it feels like a pen, it's a pen. Okay? So here's the neat little way the brain is organized so that visual input comes here, tactile here, auditory here. And this area makes it possible for us to have complex concepts and the miracle of human language. To be able to speak in all these different categories, to say something like book and think of all kinds of books and words and what it sounds like, etc. If I said to you pen, image here, so you can visualize, all made possible by this area of the brain. If your stroke was right here, cut off, you could see it, you wouldn't be able to tell me what it is. You could see it. What is this? Well, the visual input, even though you can see it, even though you can show me what to do with it, if it's cut off from here, you're not going to be able to say the word pen. You're not going to be able to do it. You would not. It's a thing, the writer thing. It's you wouldn't be able to come up with the name. Here's the trick. Let's say, cool way the brain's organized. Your damage is here. I'm showing it to you. What is it? You can't name it, but I put it in your hand. You go, it's a pen.
That's what I meant.
Yes, because it can go another way.